juice that's made in your stomach, and your pancreas and your liver doesn't have anywhere to go. You can't leave a dead end, right? So we hook everything back together, and now your digestive juice joins that food. See, look where things are connected down here. So food goes from here, down here, and then joins the digestive juice here. This no longer seeks food. This duodenum, this is very important for diabetes. And all that digestive juice joins down here. Now, we call it malabsorptive. Not to get too much into the technical of that. You don't actually poop that many calories into the toilet. You probably do absorb almost all of your calories eventually. So it can cause some issues though, because that part of the duodenum is the best part of your body at absorbing iron and calcium, and that, so you do tend to be more malabsorbed through building blocks. If you supplement, if you take basically double a multivitamin, 95% of people will get into no trouble or very rare trouble. Certainly women who are in the childbearing years can have anemia anyhow, or have anemia even coming in. A lot of people who are clinically severely obese already have bone calcium problems, and it can intensify a bit. So we do want to try to fix those problems beforehand if we can. But those are long-term metabolic issues that you do need to follow a little more closely. Now, I already talked about the direct hormonal effect. Even prior to any weight loss, and even if people regain weight, there's still durable anti-diabetic effect. Additive, I should say. You've got a version of this just to show the basic operations. The sleeve gastrectomy, I call this to friends and even to patients just sort of a half of a gastric bypass, because we're not really doing any small bowel work, and it's not truly half a gastric bypass. We're actually removing part of the stomach. We're taking this football-shaped stomach and turning it into a banana-shaped stomach, removing about 80–90% of the volume. I'm going to speed up a little bit. Common misconception is that bypass is open and the band is laparoscopic. 98% of our bypasses are done laparoscopically, and probably more than 90% nationwide at this point. So bypass doesn't mean that you're going to have a big incision. It's also a misconception that big incisions are inherently dangerous. You do have a higher hernia rate. We try to avoid it. There's more pain after having a bigger incision. But if it's needed for safety, safety first. This is not a stupid doctor trick operation, okay? If there's any compromise of safety to stay laparoscopic, we don't do it. We make an incision, whether it's your gallbladder, your appendix, anything. It's nice to be minimally invasive, but not excessively minimally invasive. Again, we're treating you, not the Band-Aids. That's true of any operation. Procedures on the horizon, I wanted to throw these in. This is a great mini med school kind of thing. Intragastric balloon, I got a picture on the next slide to show you on that. Gastric plication, you'll read a little bit about. Most docs have not ever even heard of that. There's some things out there that have not worked so well. Vagal stimulation, the vagus is a nerve that goes to and from the stomach, and people are trying to tune the signal that goes to your brain for satiety. It seems to work really well in a few people, but the deeper they dig on it, the more they can't figure out who those people are, and they're starting to wonder if it's a placebo effect. But there's some work going on that, and I think there's more room. There's plenty of room for research. Plenty of research happening. Endoluminal is surgery that happens through the mouth or through the bottom or through the vagina. You'll read about what's called natural orifice surgery, not leaving any scar at all. Young star surgeons are out to make their mark. Laparoscopy changed the world. Now they want to go the next step. And everybody is excited about this. We'd all love to do Star Trek surgery. The old surgeons, 30 years ago, 20 years ago, said, why take a gallbladder out through a little incision? I can do it through a 3-inch incision. Well, the evidence showed, as we got better and we got better tools, that it was safer to do a lot of these operations laparoscopically. The evidence is not there that having 5 Band-Aids is more dangerous than having no Band-Aids in them. Holes where they, So it's an interesting concept. Some careers will be made. There will be certain procedures that do well that way. But don't look for that to take over the world in the next 3 years. Endoluminal, natural orifice, scar-free. There's all sorts of names. Every company that makes a tool has come up with their own little thing. Single port is kind of cool. We're trying to use fewer ports, leave fewer incisions. Again, risk-benefit wise, as long as it goes okay, I've done a couple of single port operations. You could not find my scars. I mean, I have a little hair on my tummy, but they're pretty small in the first place, so it'll be out there, but don't be oversold on it. The sleeve is really getting a lot of traction. Medicare has actually created its own code for that, and hopefully within the next year or two, Medicare will cover it. Cigna, United, Aetna, 3 or 4 big companies are covering it now. I heard that Peace Health Eugene is trying to get it covered. The surgeons down there, they have the program in Peace Health. Duodenal switch, I'll skip it, but it's interesting. We'll probably end up offering it here. Here's the balloon, picture of the balloon. That's a scope. You can't see it real well here. That stripy thing up in the top is an endoscope. That's a gastroscope we put into the stomach. This goes in through the mouth. It sort of looks like a grapefruit filled with fluid. And it just sits there for about 8 weeks to 6 months. And it's designed to be trapped in the stomach. It helps reduce appetite and make you feel full after meals once you stop puking. Apparently the first 2 days you have there's a real high intolerance rate. It also in a few people can deflate. There's some stuff, it's not FDA approved, there are trials, but it's an interesting concept. I think a lot of people use it to sort of test drive satiety. With my own surgery, I worried, is it really going to work for me? I think I'm too naughty. It's not going to work for me. This will allow people to say, okay, no, it can work for me. As an indicator, as a trial run, without having a commitment. Because having surgery is a commitment. This gastric plication is an interesting thing too. Just out really in the literature in the last year, instead of actually removing that 3/4 of the stomach, just folding it in and sort of turning it into a narrow tube that way without actually removing tissue. One of the advantages of this is these staple loads are expensive, and also we're not removing tissue that we can't put back. Potentially we can go unfurl this if somebody needs that stomach for something later. You'll hear more about that. I'll probably be offering it as an experimental procedure because that is truly what it is. We don't have great data. We know there's good weight loss. We don't know how durable. That's reminding me to wrap it up here. This is stuff I put out just so you know we're talking to the docs. I concede that I have a perceived conflict of interest, but your primary care doc has less bias. But if they don't actually have the evidence, then they need to get it. We need to take it to them. I've had as many patients educate their doc as the other way around. I shouldn't say that. I mean, docs work very hard to understand, but a primary care doc has about, 80 areas of medicine to understand, and this is your deal. So don't get too uptight if they're a little behind. This stuff is in evolution pretty quickly. So I'm trying to push them to basically to send patients to me to get the evidence. You can come have a consult with me or with Dr. Billing or Landerholm or Dr. Louder. You know, that's not a commitment to surgery. That's getting more information. So these are the papers that I quote to them. The big mortality risk reduction papers. The docs like to hold the paper. They like to read it. They like to know that it was written by somebody who didn't have too much of an axe to grind and based on a big population. These are really good studies. Adams from Utah, New England Journal of Medicine, not a surgical, article. Christou is a surgeon in Quebec, but they studied Quebec and they got all the data. Anyhow, so very good stuff. I'm not going to. We talked about low BMI a little bit before for diabetes. We're getting to these hormonal impact factors. People are breaking them down and studying them. The vagus nerve, vagal afference is the name of that part of the nerve that basically tells how stretched your stomach is. One of the things it does. The foregut hypothesis, when I showed you that duodenal sweep, when that duodenum no longer sees food, it does some things that are the opposite you would think. You'd think it would go crazy wanting more food. Anyhow, so this stuff is being worked on in research labs at the molecular level. That's what you're paying your tax dollars for, and I think to good effect on some of this, ultimately. And the hindgut, so there's part of that lower gut that's now seeing food that really didn't before because digestion happens so well in the upper gut that the lower gut does not see a lot of calories. Well, now it is when you do a bypass, and that has some hormonal impact as well, on diabetes in particular. So some of these experimental surgeries where they move part of the lower gut up to the top, that's what you'll hear. And that's what the Indians and the Chinese, Indians are trying to do, is make non-weight loss operations where you take somebody who's 110 pounds and you don't have them lose more than 5 pounds, you just move stuff around enough to get the hormonal effect. So that's where this stuff is important in designing new operations. Short term on that, though, is that the bypass actually seems to do pretty well, and most people who aren't heavy don't lose more than about 30 pounds. And all the other stuff doesn't seem to be quite as effective yet. It's very early. Worldwide epidemic, we've talked about set point distortion a little bit. I got to skip this stuff. I'm sorry. I always try to put in too much stuff. Cancer risk data, risk of getting and risk of dying of it once you get it is higher when you're heavy than clinically severely obese, not just 20 pounds overweight. And that new data we talked about with childhood risk. The OBGYN doctors care a lot about this for infertility. They do in vitro fertilization for women with a BMI over 40 usually. We used to worry a lot about getting pregnant after bariatric surgery. You still have to be careful about it, but it's not nearly the risk as we thought it was. It had more to do with moms who weren't able to get pregnant for 20 years, and then at 42 they got pregnant. And you know, they have higher risk as a 40-year-old mom than they would have as a 20-year-old mom. One very interesting thing I cannot resist saying here, though, the epigenetic, I love saying the new words, that is the fetus's environment. You know, when you take a fetus, it is genetically whatever it is, but the epigenetic is basically the womb. And when the womb has a diabetic mom around it, or a mom who's heavy and we don't even know what hormones are affecting, you know, the ghrelin and things like that. Women who've had surgery, weight loss surgery, and had a kid after that tend to have skinnier kids, kids who are not as susceptible to obesity, and they don't think it's just related to the home environment where mom is eating better than she was. They really think there are things that happen pre-birth to some of the set points, the way these, you know, that brain is growing in an environment. Early stuff. Fatty liver is the other big risk for kids. There's going to be a lot of people needing liver transplants before age 30. But this is now the second leading cause of cirrhosis, fatty liver. The younger you get it, the younger you have the inflammation, the more risk you have of getting cirrhosis. It's probably going to be the leading cause of cirrhosis in a few years. Adolescents are a handful. This is an hour-long slide. There's a lot to talk about. I don't want you guys to think that I'm flip about how, you know, we take care of kids. But I also put to you, if you have a 12-year-old who needs a kidney transplant, but he's smoking pot and his parents aren't responsible, you say, sorry, you got to die. You don't have a good home environment. We can't work with you. No. You figure out how to get that kid to a kidney transplant, right? If you're a doc, what can we do? We got to work. We're not going to just give you a kidney that we think is going to fail, but we're not going to give up. And we shouldn't give up on kids just because they're heavy in a bad home environment or a, you know, dysfunctional environment. We have to remember that we're not God and we can't save everybody, but I think a lot of times we want to give up too easy. Racial disparity in access to care and economic disparity, this is where advocacy comes in. And so this Obesity Action Coalition is so important. Just get familiar with it, even if you don't get signed up. Employers and insurance administrators, I started with the talking about that. Your voice really matters. The County Medical Society, and hopefully a regional task force will be able to do more and more working together at all layers from Parks and Rec. You know, they have great plans to put trails in Bellingham where no kid in this town is more than a half a mile from a trail. You know, those are so important. So, it's not my direct job, but I hope to, as a community person, participate in that. Costs, whole hour-long talk. It costs a lot. Diabetes costs a lot. Return on intervention. This is the stuff I'll take with you if you want me to go to your HR department and show them where the savings are. What can we do? Change your mental model of the disease, support comprehensive care, advocate. Individual, when you go home in your neighborhood, I can't tell you how many nurses come to me and is like, well, my neighbor comes to me and expects me to be an expert on this because I work at the hospital where they do the surgery. I'm like, well, great, let's give you information. You can be a resource, you know. People, you know, my wife is most non-medical person in the world, and on our hockey team, when somebody got a cut, they skate right over to her. She's like, whoa. But you guys, you know, the word doesn't just spread from the surgeon, okay? The word spreads through a community. And the more information you have, the more your loved ones have support, the more they have understanding. And so don't be afraid of a one-on-one consultation. It's not a waste of my time to talk to somebody who says, not for me right now, I'll be back in 2 years, I'll be back in 5 years, or, you know, that's fine. I'm happy to talk. You don't often know until you talk one-on-one what your risks are.